Good evening, everyone. I thank the organizing team for this opportunity. Let's get straight into our talk, which is titled 27-Year-Old Saga Darkness to Light. Now, this title came from a written note by a patient's son after the procedure, expressing their feelings. In those lines, I found this very line where he mentioned that his father, after 27 years, has started seeing things clearly. Let's jump into the case details now. So, this is a 55-year-old gentleman with history of trauma 30 years back. The details of management at that time were not available, and he had poor vision since then. He had assumed that the eye is permanently damaged up until he developed cataract in that eye, which he recognized after it became white. He was advised elsewhere to have SICS with PMMA IOL. So on examination, he had perception of light and accurate projection of rays. The right eye showed dense scar with adherent iris along the inferior edge of the pupil. Apart from the standard tests like biometry, ultrasound, specular microscopy, he had a corneal topography to understand the effect of the scar on the cornea. So there was approximately 6 diopters of astigmatism. Topography also showed that there was a bow-tie configuration, but with an asymmetrical flattening more inferiorly. Also, there was slightly decentered image, which was due to poor fixation, obviously due to total cataract. So based on this, we understand that the patient's outcome with toric iol in this case may not be perfect, but will surely lead to reduction in total cylinder. There were other concerns also, as we were not sure of the density of the cataract that was quite long standing, and also the sonnular status, especially inferiorly, was not clear. This was the calculation on Barrett's toric iol calculator, and the IOL was chosen. So on table, I decided to sit superiorly for better field of view. 28-degree IOL placement axis is marked. Two side entries are made. Here is the main incision. After staining the anterior capsule, a cohesive viscoelastic 1.8% sodium hyaluronate is used to form anterior chamber, and anterior capsule is flattened. We make a curvilinear neck, and then decompression is done. Capsular axis is done, and concentrically the diameter is increased. Phacoemulsification was completed, and toric iol was dialed into correct axis, and the case was closed. Coming to the results, we were pleasantly surprised to see an uncorrected visual acuity of 6 by 18 parts, which was improving to 6 by 9 with this refraction. IL was at 24 degrees against a planned axis of 28 degrees. So I would say the take-home points in this case is topography is must in all cases of corneal scar to ascertain the suitability for toric IOL. Phaco should be attempted in these cases, and the site of incision can be decided on table depending on the ergonomics and the field of view. One should not hesitate to implant toric iol in these cases even if one is not sure of the precise outcome, as there will be overall increase in the quality of vision. Thank you so much for your kind attention.